Hi there, my highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very, very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very, very precious time to share with you some useful tips which may prove handy in your line of duty. So I welcome you to part 91 of our pharmacotherapy MCQ series, majoring in basic oncology. Our first question reads, medications in the class of tyrosine kinase inhibitors, abbreviated as TKIs, have revolutionized the way we manage patients with chronic myelogenous leukemia, which is abbreviated as CML. Interferon-based therapy is no longer first-line treatment in this cohort of oncology patients. So my question to you is, which of the agents listed below are considered appropriate as first-line treatment options for CML patients? Is it imatinib, dasatinib, and sunitinib, or is it nilotinib, dasatinib, and sorafenib, or is it imatinib, nilotinib, and dasatinib, or is it sorafenib, sunitinib, and imatinib? I'll give you 10 seconds to choose the correct trio. Correct answer is imatinib, nilotinib, and dasatinib. Now, imatinib was the first molecular targeted therapy approved by the FDA for the treatment of cancer, and it was approved for CML therapy in May 2001. Then later, the second generation TKIs such as dasatinib, nilotinib, and bosutinib have shown activity in the first and second line setting of CML management. Just like to add that imatinib, dasatinib, and nilotinib, together with the bosutinib, all inhibit BCR-ABL activity, which is responsible for the pathophysiology in about 95% of CML cases. Sorafenib and sunitinib don't inhibit BRC-ABL activity and are therefore not effective in the management of CML. Remember that. I would like to add that second generation TKIs lead to quicker molecular response and higher rates of deep molecular response. They may be preferred in younger patients, especially women, considering a deep and rapid molecular response may lead to eventual discontinuation of the TKIs for fertility reasons. And remember, imatinib may be preferred in older patients with comorbidities, especially the cardiovascular diseases, because of safety reasons. Let's move to the next question, please. And it reads, which of the monoclonal antibodies listed below is correctly matched with its corresponding target and black box warning? Is it pertuzumab, which corresponds to the HER2 receptor and causes pneumonitis, or is it eculizumab, which corresponds to the complement protein C5 and may cause meningococcal infections, or is it bevacizumab, which corresponds to the VEGF receptor and may cause nephrotoxicity, or is it brentuximab vedotin, which corresponds to the CD20 and may cause PML? I'll give you 10 seconds to choose the correct answer. So eculizumab, complement protein C5, and meningococcal infections it is. Now I'd like to remind you that eculizumab is a monoclonal antibody that binds to complement protein C5, and it has a black box warning for life-threatening meningococcal infections, for which patients should either receive prophylaxis with vaccines or antibiotics. Now, due to the risk of meningococcal infections, eculizumab is only available through what we call an REMS program. Although bevacizumab binds to VEGF receptor, its black box warnings are GI perforation and severe or fatal hemorrhage. So there was a mismatch there. It has nothing to do with nephrotoxicity. And I would like to add that although brentuximab vedotin has a black box warning for PML, its target is the CD30. So D is also wrong. And then although pertuzumab targets HER2 receptor, the black box warning there, if I remember well, is for cardiac failure. That is, it produces a decreased left ventricular ejection fraction and not pneumonitis. So that makes answer A wrong as well. Let's move to the next question. And it reads, Mrs. P.P.T, a 67-year-old female patient, is receiving her 6th cycle of Cisplatin for confirmed metastatic ovarian cancer. Considering her labs, she is experiencing some nephrotoxicity from Cisplatin. So my question to you is, which of the electrolyte abnormalities listed below would indicate Cisplatin-induced nephrotoxicity? Would it be hypokalemia and hypophosphatemia? Would it be hypokalemia and hypomagnesemia? Or would it be hyperkalemia and hypermagnesemia? Or would it be hyperkalemia and hypophosphatemia? I'll give you 10 seconds to choose the correct answer. So the correct answer there is hypokalemia and hypomagnesemia, and I'll explain why. The GFR decreases with repeated cisplatin cycles, that is written in literature. Now, upon cisplatin cessation, renal function may or may not improve. Then hypomagnesemia is a common finding from cisplatin administration, and is usually due to renal defect in magnesium absorption. Now, secondary wasting of calcium and potassium may accompany this situation, and another potential mechanism of cisplatin nephrotoxicity proposes a distal tubular acidosis leading to tubular wasting of hydrogen, magnesium, potassium, and even calcium ions. So it's also written widely in literature. Let's move to the next question, please. And it reads, which of the agents listed below possesses minimal emetogenic potential? Is it ifosfamide, binorelbine, carboplatin, or temozolomide? I'll give you 10 seconds to choose the correct answer. So binorelbine it is. Now I'd like to start off by saying that carboplatin and ifosfamide and high doses of temozolomide all tend to be moderately emetogenic. Now remember, if temozolomide was dosed at 75 milligrams per meter squared or lower, then it would be considered low risk emetogenic. I'd like to emphasize that all the vinca alkaloids, that's vincristine, vinblastine, and binorelbine, are considered minimal risk or minimal emesis risk, and that explains why B would be our correct answer in this particular question. Let's move to the next question, please. And it reads, Mr. JPA, a 65-year-old male patient with an extensive history of smoking, was recently diagnosed with metastatic non-small cell lung cancer, and your medical oncologist plans to initiate him on platinum-based chemotherapy. Mr. JPA is pondering whether to opt for Carboplatin or Cisplatin as part of his chemotherapy regimen. He inquires from you, as the oncology clinical pharmacy specialist, any key differences between Cisplatin and Carboplatin. So my question to you is, which of the statements listed below illustrates the best comparison between Carboplatin and Cisplatin? Is it true that Carboplatin has a lower risk of myelosuppression? Or is it true that Cisplatin has a higher risk of emesis and nephrotoxicity? Or is it true that Cisplatin dose is calculated by the Calvert formula? Or is it true that Carboplatin infusion requires pre and post hydration? I'll give you 10 seconds to choose the correct answer. It is true that Cisplatin has a higher risk of emesis and nephrotoxicity. Remember, Cisplatin is highly emetogenic and causes significant acute and delayed emesis. Now, while Carboplatin can cause emesis, it has a significantly lower risk than Cisplatin. I'd like to add that Cisplatin has a higher risk of nephrotoxicity, which is its limiting toxicity. It should be given with pre and post hydration, and many patients are at a risk of increased Cisplatin induced nephrotoxicity should be considered for Carboplatin switch instead. Now, to mitigate Carboplatin induced toxicities, the dose of Carboplatin is calculated based on area under the curve using the Calvert formula, which accounts for renal function fluctuations. Remember that. I'd like to add that patients on Carboplatin are at an increased risk of myelosuppression, not at a lower risk, and that makes answer A wrong. And then according to the ASCO guidelines, mifostine may be considered for the prevention of nephrotoxicity in patients receiving Cisplatin-based chemotherapy. That's just by the way. Let's move to the next slide, please. And the next question reads, which of the statements listed below is true with regard to targeted therapy for HER2 positive breast cancer? Is it true that patients who progressed on Trastuzumab or Herceptin can be switched to ado-Trastuzumab emtansine, which is marketed as Kadcycla, to overcome Trastuzumab resistance? Or is it true that Pertuzumab, which is marketed as Perjeta, doesn't have a black box warning for cardiotoxicity like Trastuzumab does, because it targets a different epitope on the HER2 protein from Trastuzumab, which is marketed as Herceptin? Or is it true that patients who progress on Trastuzumab, Herceptin that is, can be switched to Pertuzumab, which is marketed as Perjeta monotherapy, to overcome Trastuzumab resistance? Or is it D, ado-Trastuzumab emtansine, which is marketed as Kadcycla, is a novel antibody conjugate that contains a monoclonal antibody, which is Trastuzumab in this case, connected to an alkylating agent, emtansine in this case? I'll give you 10 seconds to choose the correct answer. So A is the correct answer, and I'll explain why. Now, trastuzumab binds to subdomain 4 on the HER2 extracellular domain and blocks HER2 cleavage. And that leads to antibody-dependent cell-mediated cytotoxicity and inhibiting ligand-independent HER2-mediated signaling. Now, pertuzumab binds to subdomain 2 and it inhibits the formation of HER2 to HER3 heterodimer formation, and can be used synergistically with trastuzumab to overcome trastuzumab resistance. However, both agents have black book warnings for cardiotoxicity. Now remember, pertuzumab has a low response rate as a single agent for HER2 positive breast cancer, and is only approved in combination with docetaxel and trastuzumab as either neoadjuvant therapy for early stage breast cancer or as treatment for HER2 positive metastatic breast cancer who haven't received prior anti-HER2 therapy or any chemotherapy. Then I would like to add that ado-Trastuzumab emtansine, which is marketed as Kadcycla, is a HER2 targeted antibody drug conjugate that consists of an antibody trastuzumab and a microtubule inhibitor DM1, or in other words emtansine. Now, after binding to the subdomain form of the HER2 receptor, ado-Trastuzumab emtansine undergoes receptor mediated internalization and subsequent lysosomal degradation, and that results in an intracellular release of DM1 containing cytotoxic catabolites and microtubule inhibition. Very long mechanism of action. I would encourage you to read about it in literature. Let's move to the next slide, please. Reached. Mrs. P.L.K., a 68-year-old female patient, presents to your oncology clinic with complaints of urination frequency accompanied by burning on urination. She has a history of urinary tract infections during which cultures grew E. coli susceptible to most antibiotics with an exception of ampicillin and cefazolin. She has non-Hodgkin's lymphoma and she has already received 2 cycles of rituximab and bendamustine. Currently she takes simvastatin, amlodipine and PRN prochlorperazine, and she has no known drug or food allergies. The medical oncologist intends to initiate her on an antibiotic for this presumed urinary tract infection, and he wants to start her chemotherapy in 2 days' time if this lady improves with antibiotic therapy. So my question to you is, which of the antibiotics listed below would be the most appropriate in this clinical scenario? Is it Cephalexin, levofloxacin, ciprofloxacin, or amoxicillin? I'll give you 10 seconds to choose the correct antibiotic. Levofloxacin it is. Now I'd like to start by saying that amoxicillin and cephalexin wouldn't be acceptable options since Madam PLK has a history of resistant E. coli to similar antibiotics. Remember, it was resistant to cefazolin, which belongs to the same class as cephalexin, and to ampicillin, which is very similar to amoxicillin. Now, bendamustine is a CYP1A2 substrate while ciprofloxacin is a strong CYP1A2 inhibitor. Now, since there could be an interaction between these two agents, this combination should be avoided. We should avoid co-administering bendamustine with ciprofloxacin. So ciprofloxacin, answer C, becomes the wrong choice. And I would like to add that levofloxacin isn't an inhibitor of CYP1A2, so it would be a better option in this case. Let's move to the next question, please. And it reads, your medical oncology will be initiating bevacizumab shortly for one of your oncology patients. My question to you is, which of the side effects listed below doesn't require permanent discontinuation of therapy using bevacizumab? Is it reversible posterior leucoencephalopathy syndrome? Would it be proteinuria? Or is it non-gastrointestinal fistula formation? Or is it a myocardial infarction? Or is it the nephrotic syndrome? I'll give you 10 seconds to choose the correct answer. Proteinuria it is. Now, proteinuria occurs in approximately 20% of patients, whereas nephrotic syndrome occurs in less than 1% of bevacizumab patients. Now, if 2+ protein is found on urinalysis, a 24-hour urine collection should be conducted. Now, if over 2 grams of protein in 24 hours is detected, then bevacizumab should be withheld until the urine protein is below 2 grams within 24 hours. Now, the presence of nephrotic syndrome necessitates permanent discontinuation of bevacizumab. Harm could be caused if you re-challenge or if you initiate it. So all those many words make alternative B the correct answer. Let's move to the next question, please. And it reads, GWB, a middle-aged patient, is being managed for AML at your oncology clinic. My question to you is, which of the toxicities listed below would not be expected with the use of high-dose cytarabine, that is 3 grams per meter squared IV every 12 hours times 6 doses? Is it cerebellar ataxia? Is it hemorrhagic cystitis? Is it conjunctivitis? Or is it myelosuppression? I'll give you 10 seconds to choose this correct answer. I wouldn't expect any case of hemorrhagic cystitis. Now, since cytarabine is used for leukemia, it is expected to produce profound myelosuppression, and at high doses cytarabine can induce cerebellar ataxia. It's recommended that nurses and physicians should evaluate the patient before each dose of cytarabine to ensure the patient doesn't exhibit any symptoms, just as a caution. And then high-dose cytarabine is found in tears and can lead to conjunctivitis and even keratitis, so be very, very careful. I would just like to add that steroid eye drops should be used during cytarabine administration and for 48 hours after cytarabine infusion ends, in case conjunctivitis or keratitis ensues. I would just like to add that cytarabine is known to cause hemorrhagic hemorrhagic cystitis, which is more common with cyclophosphamide and ifosfamide. So that makes answer B the correct one. We do not expect hemorrhagic cystitis. That is common with cyclophosphamide and ifosfamide, not with cytarabine. Let's move to the next question, please. And it reads, Mrs. D.D.K., a 60-year-old female patient, presents to your clinic with early stage breast cancer. Your oncology team did a receptor evaluation which revealed an estrogen positive, progesterone negative, HER2 positive tumor. The EGF receptor analysis wasn't performed by the team, so my question to you is, which of the receptors expressions listed below is likely to be positive in 15 to 25% of patients diagnosed with breast cancer? Is it the progesterone receptor? Is it the EGF receptor? Is it the HER2 receptor? Or is it the estrogen receptor? I'll give you 10 seconds to choose the correct answer. HER2 receptor it is. Now 15 to 25% of breast cancers are HER2 positive, which is associated with a more aggressive tumor. While it's considered a poor prognostic factor historically, there are now multiple agents including ado-Trastuzumab, emtansine, pertuzumab, trastuzumab itself, apatinib, and even neratinib, which are efficacious in HER2 positive breast cancer cases. Now, the majority of patients present with estrogen or progesterone receptor positive tumors. Just like to add that estrogen and progesterone receptor positivity is considered a good prognostic factor. I would like to emphasize that all newly diagnosed breast cancer patients should undergo initial estrogen receptor, progesterone receptor, and even HER receptor testing. That helps tailor make your therapy well for efficacy or effectiveness. Let's move to the next question, please. And the question reads, Mr. J&M, a 60-year-old male patient, was diagnosed with metastatic bladder cancer by your medical oncologist, who decided to initiate gemcitabine and cisplatin chemotherapy. So my question to you is, which of the statements listed below best describes gemcitabine? Is it true that gemcitabine is an anti-tumor antibiotic which has thrombocytopenia as its dose-limiting toxicity? Or is it B, gemcitabine is an anti-tumor antibiotic which is administered every 2 weeks? Or is it C, gemcitabine is a pyrimidine analog which has thrombocytopenia as its dose-limiting toxicity? Or is it D, gemcitabine is a pyrimidine analog which is administered every 2 weeks? I'll give you 10 seconds to choose the correct answer. So gemcitabine is a pyrimidine analog which has thrombocytopenia as its dose-limiting toxicity. Remember, gemcitabine is a deoxycytidine analog that inhibits DNA synthesis by inhibiting ribonucleotide reductase. It also incorporates into DNA and inhibits DNA polymerase. Now, there was a landmark trial of gemcitabine co-administered with the Cisplatin, which was abbreviated as GC, compared to methotrexate, vinblastine, doxorubicin, and Cisplatin, which were commonly called MVAC, and these were metastatic bladder cancer patients, and 57% of them who received GC had grade 3 or more thrombocytopenia, as compared to 21% who received the MVAC, in addition to 37% of the GC cycles which required dose adjustments, and thrombocytopenia was one of the primary reasons for dose adjustment. And thus, thrombocytopenia can be considered a dose-limiting toxicity in the case of gemcitabine therapy. Now, I'd just like to add that gemcitabine isn't an anti-tumor antibiotic. That description applies to bleomycin. Now, when given with cisplatin, gemcitabine is administered weekly on days 1, 8, and 15 of the 28-day cycle. Now, if you opted for the 21-day cycle, then it would be administered on days 1, 8 specifically, and that is it. And it isn't administered every 2 weeks at all. That would be the wrong dosing schedule. So there you have it, my highly esteemed viewers and listeners. That brings us to the end of this video. And if this video benefited you in any way, I would like to humbly urge you to give it a thumbs up, to like it, to share it widely with your peers, and to leave a comment at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come. And thank you very much for viewing this video and for listening to me. And I sincerely appreciate your partnership, your continued support, and your very kind collaboration. And I look forward to interacting with you in subsequent videos. Thank you very much.